Welcome to Live on Tuesday, hosted by ZimV Education. I am Catherine Shireman, the Territory Sales Manager in Eastern and Central North Carolina for ZimV Dental, and I'll serve as the moderator for this evening's program. The topic for the program tonight is Trusting Bone Graft Properties, Insights into Their Reliability and Performance. I'm excited to be joined by our presenter, Dr. Elnaz Ajami. Let me tell you a little bit about her before we begin. Dr. Ajami joined ZimV in 2016 as a research manager, bringing a wealth of expertise to the role. In her capacity, she holds a pivotal position overseeing both internal and external preclinical research endeavors, which encompass benchtop testing and animal research. A testament to her strategic leadership, Dr. Ajami also manages collaborations with esteemed researchers from select universities worldwide. Dr. Ajami holds a master's degree in clinical engineering from the University of Liverpool in the UK and earned her PhD in biomaterials science and engineering from the University of London in the UK. Prior to her role at ZimV, she spent 6 years as a postdoctoral research fellow at the Institute of Biomaterials and Biomedical Engineering at the University of Toronto in Canada, where she spearheaded multiple research initiatives collaborating closely with ZimV. Dr. Ajami's contributions extend beyond the laboratory with over 20 high-quality publications in the field, some of which have garnered more than 100 citations.
Thank you so much for the introduction, Catherine. I'll take it over from here. And hello, everybody on the line. It's my pleasure. It's an honor to be here today talking about some of the research that we have done in the lab on different allografts. And as I myself have faced a lot of misconceptions about allografts, I wanted to address it and see it for myself. We did it, finally. It got published. I'll be sharing some of the information from basically the research that we have done for the course of 3 years. So in this today's presentation, I will be covering a few topics, starting with different processing that is undertaken by different tissue banks on the bone tissues, bone allografts. Briefly talk about graft incorporation, and then I'll move on to the effects of tissue process on the properties of allografts. And finally, close it with showing the effects of allograft properties on the clinical performance of these bone grafts. I want to start off by talking about some of the common or 3 major processing methods for bone grafts. Fresh frozen is one of them, which is obviously not the focus of today's talk, but briefly with this method, the allografts are put through an antibiotic wash to reduce the risk of disease transmission and immunogenicity. With this method, the BMP is preserved and osteoinductive properties are maintained. The graft is then cooled at around -70 degrees and can be kept at -20 for the shelf life of 5 years. In today's practice, however, freeze-dried allografts are more popular, as well as the one and only solvent dehydrated or pseudoplast process that Puros allograft is prepared with, and it's a unique product, which we will get into details shortly. I'll start off with the pseudoplast process and then move on to talk about freeze-drying method. The pseudoplast process is a proprietary 5-step process developed more than 50 years ago to sterilize and preserve bone and soft tissue. The process distinguishes itself through its meticulous approach to tissue preservation. It involves about 27 washes in 5 processing phases and over 39 days to have the final product ready. Yes, it is very slow, and at the same time, a gentle process involving a controlled series of solvent exchanges to gradually replace water content with solvents, preserving the fine details and microarchitecture of bone to the best possible. This is something that we will be talking about throughout the presentation today. And even solvents that are used in this process are carefully chosen for their compatibility with the tissue to not cause excessive shrinkage or damage to the tissue throughout the process. The process starts, as you can see on the slide, with removing lipids in ultrasonic acetone bath. This step inactivates enveloped viruses such as HIV and reduces prion activity by almost 2 logs. In the second step, bacteria are destroyed by a series of alternating saline and distilled water bath. The process ruptures cell membranes, kills bacteria, and washes out all the cellular and bacterial debris. It also removes antigens and exposes any viruses that may be present, which would be removed in the subsequent step. And it's in third step, with the oxidative treatment, soluble proteins are eliminated and non-enveloped viruses and bacteria are destroyed by the use of hydrogen peroxide. Basically, at this point, we have gone through all the envelope DNA, RNA, and any sort of viruses that one can think of. And lastly, an acetone wash assures removal of any residues. At this point, a vacuum extraction is conducted, which dehydrates the tissue so it can be stored at room temperature. And finally, the graft is terminally sterilized with low-dose gamma irradiation. This final step alone reduces the chance of viable microorganisms on the final product to 1 in a million. Moving to freeze drying or lyophilization, it is another dehydration method that is commonly used to reduce the water content of the tissue. It's a method that most of the allografts, except Puros, go through this process by different tissue banks. While different tissue banks have their own proprietary methods in terms of disinfecting and rinsing the tissue, the basics of removing the water content with freeze-drying method is the same. It's a short 3-step process, doesn't take as long as pseudoplast, and it starts off by deep freezing bone tissue at -80, so the water is crystallized. In the second step, the tissue goes through 2 drying processes. The primary drying, where the surrounding pressure is reduced, and then continuous heat is applied, so the frozen water would sublimate directly from solid phase to gas phase. In this phase, any unbound or free water is removed. And in the secondary drying phase, the bound water is removed. Therefore, because of the high resistance to heat, the drying rate is significantly slower than the first phase. With this technique, water content is reduced to less than 6% of its initial weight. Therefore, it does not support any biological activity or chemical reactions in the tissue so that it can be stored and it has a shelf life. So at this point, you can easily tell how different the 2 techniques are. And it's just so unfair to assume that the products that you're going to get out of freeze drying and solvent dehydration, which are 2 completely different processing methods, would have same properties and would perform similar clinically and give similar clinical outcomes. And indeed, there was a study that was published back in 1990s. It's been quite a while that it talked about factors contributing to the incorporation of grafted bone. And not surprisingly, the preservation technique was listed among many other host and graft-related factors, such as the type of the graft, whether it's allogeneic, xenogenic, the site of transplantation, whether it's in maxilla or mandible, quality of patient's bone, the way the osteotomy is prepared, patient's medical history, whether they have any systemic or local diseases, and mechanical properties of the graft, all of which have direct impact on the incorporation of the graft. And bone graft incorporation is really a very complex, multifaceted process, and multiple variables influence its rate, pattern, and completeness. Although the graft and perigraft environment, each of them have separate contributions to this process of incorporation, it's the sum of their interactions that determine the success or failure of the graft. For successful graft incorporation, a balance and appropriate match has to be made between the biological activity of the bone graft, the condition of perigraft environment, and the mechanical environment. So what it means is that, for example, if you have a less biologically active and more dependent graft on the perigraft environment, the better environment must be for a successful graft incorporation. Or conversely, the more biologically active the graft is, the more an attenuated perigraft environment will be tolerated. So it's not just one factor, but there are several factors that come into play for the successful incorporation to happen. In today's session, I'll focus more about the properties of the graft and their impact on the biological activities of the graft for the successful incorporation to happen. And I love this quote from Stevenson that says it's actually the task of the clinician who is performing the bone grafting procedure to choose the right graft or combination of them for that specific biological and mechanical environment that grafting is happening. The paper, even though it's an old one published in 1996, it's a really useful one if you guys are interested in some good reading material, and the reference is shown on this slide. So with all that I discussed, when you hear somebody telling you that bone is bone, why do I pay more for a particular allograft while they are all from cadaveric human bone? What would you say? I would say the answer is yes, bone is bone, but until the tissue is processed. So the moment the processing of the human tissue starts, you can never guarantee it's going to be the same bone as was started with. And as you will hear today, and probably you already know, the processing methods that different tissue banks take, either freeze drying, pseudoplast, or whatever else, they are all different. There are many variables that come into play that changes the properties, microarchitecture, physicochemical properties of the bone tissue, and the final packaged allograft bone tissue are not the same, even though they all come from human cadaveric bone. Factors like the concentration of media that is used during the processing, duration the bone tissue is soaked in those chemicals, the temperatures that the tissue is handled, the pressure, and there are a lot of things that all impact that bone tissue. So yes, bone is bone, but until it's processed. So not all the bone grafts are the same, and you're gonna see it for yourself in today's presentation. So just to prove this point, because we faced this sentence or this statement from a lot of doctors that bone is bone, we wanted to prove it. So we conducted this comprehensive study that got published early on last year in Ajami. And maybe some of you have already seen the article, but I'll go through some details about what we have published in this article, showing how different the allografts can be from each other in terms of their physical chemical properties and how those differences impact cellular response. So for this study, we chose cancellous particles with particle size of 0.2 to 1 millimeter range for all the allografts we chose. Puros is a pseudoplast process we talked about. It's a gamma irradiated tissue. Then we purchased Creos of Nobel from Community Tissue Services. It's a freeze-dried and gamma irradiated allograft. We had Allografts from LifeNet Health, again, another freeze-dried gamma irradiated tissue. We also had Mineros from BioHorizons, that's also freeze-dried, but irradiated with E-beam. E-beam irradiation is very similar to gamma radiation for sterilization as being an ionizing energy. But the difference is its high dosage rates and low penetration depth, limiting the sterilization of thicker materials, it's also more cost effective than gamma irradiation. Otherwise, it does the job and it's used for sterilization. The first thing that we did when we began our research was we took these allografts and they come in their original vial. We shake them to make sure that whatever we are going to take out of the vials is representative mix of what is inside. We take a scanning electron microscope stub and we pour the particles on the stub with carbon tape. We put it in the SEM and look at them. So at the first glance, as you can see here in the pictures, Puros looks like, when you look at Puros, looks like the particles are on the smaller end of the reported size range. So distribution of particles are on the smaller end. We could measure something between mostly what we measured was 0.2, 0.3, 0.5 millimeters. But when you look at other graphs, you can easily tell they are on the larger end of the size range that's reported by the manufacturing. What you measure is 0.5, 0.8, 1 millimeter. Another thing we notice at this level of magnification is that, as you can see in the red box on the bottom right picture, is what looks like some network type structure that's covering the particles on Mineros and Allograft and Orograft, and to a lower extent on Creos, and maybe here and there with Puros. So when we took a closer look at that web-looking network structure, as you can see in this blown up SEM image by white arrows, it looks like there is a film that was on the particle. It has been stretched and opened up, and you see the particle underneath. So dark gray is that organic film, whatever, and the lighter gray is the bone graft. And then when we take a closer look with what you're seeing in that yellow window, again, you're seeing it more clearly. We did EDS analysis to figure out what the exact composition of this matter was. Its chemical composition proves it's a material with organic nature. We detected nitrogen on it. So we suspected that maybe washing process or the cleaning of the organic matter was not sufficient enough that left so much of organic components on the particles. So at this point, we already know two major differences. One is this abundance of organic matter that is left on the particulates of freeze-dried, and also the large size of freeze-dried allografts that came in their original vial. But obviously that was not good enough, so we moved on. We looked at higher magnification images up to 5 to 10 times, 10,000 times, to see through the structure of bone tissue itself. Here in these images, you're looking at 1,000 time magnified images, and as you can tell, there aren't much differences at this point between Puros and other freeze-dried allografts. The overall architecture looks as if they all are the same. You're seeing same bundles of collagen fibers, typical of the bone tissue, and we are seeing it on all four. But But when we take it closer at 5,000 times magnified, you're starting to see these beautiful collagen fibrils in nanometer scale range that are distinct on Puros, but not so much on other allografts like with Creos. There are some fiber structure, as white arrows point out, but overall it looks a little bit more flat. With Allografts and Mineros, you're seeing some fibrillar structure, but as if it's covered with a film that has stretched open, as you can tell from the tears, which again is that organic film that we mentioned before. It's stretched open, and you're seeing something underneath, like here and there, a few of them, but not to the extent that you're seeing with Puros. And then we get further closer. This is 10,000 times magnification, and it even gets worse. All the freeze-dried allografts look perfectly flat, but with Puros, you're seeing those beautiful bundles of collagen fibers, even individual collagen fibers, not only the bundle on the surface, and the beautiful complexity of surface with individual fibril structure. So at this point, those who are used to seeing bone structure in SEM would confidently call the image shown for Puros bone tissue. But the other images are hard to be distinguished as bone tissue. So if you would show these images to someone unlabeled, nobody may be able to tell this is a bone tissue, because it doesn't at all look like a bone tissue at this point. We didn't stop there. We again take a further step and look at the structure of individual collagen fibrils by itself at very high magnification. There's these pictures, as you can tell with the scale bar, they were taken around 30,000 times magnified. Before explaining what pictures are showing here, just wanted to explain that naturally collagen fibers show striations in SEM. The striations are actually cross-banding of collagen fibers that overlap each other when they form during de novo bone formation. And very interestingly, we see this happening with Puros. So the striation you're seeing and the measurements that you're seeing here, they are the measurements for cross-banding distance of collagen fibers, and it perfectly matches with what is reported for natural unprocessed human bone in the literature. But when we get to that level of magnification with Allografts or Mineros and other freeze-dried allografts, it looks like something is buckled up and covering the surface, and the surface looks just flat. So you can easily tell the structure on the right is nowhere near to the structure on the left, as if the one on the right is from another tissue and one on the left is collagen. So very striking differences that we are seeing between Puros microarchitecture, how beautifully collagen structure, individual collagen fibers have been preserved as compared to other allografts. Again, note the scale bar is 500 nanometers here. You can tell these individual fibers are about 50 to 100 nanometers in diameter. So you're getting that close to the structure of collagen fibers, and you can still see it with Puros, which explains how well the structure has been preserved. And at this point, we all were confident that Puros preserved the architecture of bone better than other freeze-dried allografts. But the question remained as to how close would that be to an unprocessed human tissue. Let's say you get that cadaveric bone, you don't process it, you just want to see how it looks like. How close would that be to Puros? So we got lucky that we received some cadaveric bone samples from one of our collaborators at the University of Toronto, where they got this human bone tissue from the cadaver lab in their anatomy department for a research project. So they took that fresh bone tissue, just cleared off the soft tissue flesh from bone, gave it a very quick rinse and a little bit of antibiotics to make sure that they don't catch contamination in the culture dish. They put this tissue in culture dish and cultured osteoclasts on that bone tissue. So osteoclast obviously starts resorbing the top layer of the bone and expose the inner structure of the tissue. Then they fix dehydrated tissue, send it us for imaging. What you're seeing here on the left is the SEM image of the osteoclast resorption tray. So if you look inside this structure, this is what unprocessed human bone tissue would look like. So you're seeing all these complexity of the collagen compartment, and on the right is porous cancellous particles. So we did this thorough SEM imaging at 5,000 magnification and zoomed inside the osteoclast resorption tray, and you're seeing the complexity of surface. On the right, you look at the one of the porous cancellous particles. So I can start seeing similarities already, even though obviously porous is a processed tissue. It's not going to look 100% like unprocessed human bone, but this much of resemblance we see at this level is incredible. So again, we go further. We never stop with just one image. We take it to like different magnifications, 10,000, 20,000. The top row images that I keep scrolling is unprocessed human bone, and bottom images are from porous particulate. So when you look at porous, you can always find something that is matching, I would say about 90% with that you're seeing on the unprocessed human bone. I've taken multiple images at different orientations and cuts of the samples to show that every architecture with unprocessed human bone can also be found on porous. So again, we go further to 20,000. We can see the collagen fibers, the architecture, the orientation, they all look very close between human bone and porous. So we can, with the confidence, we can say that the structure of collagen compartment of porous and the size of individual fibrils closely resemble that produced on unprocessed human bone. So very important takeaway message here that you compare porous to unprocessed human bone and the resemblance is 80–90%. Once we saw that microarchitecture is preserved visually, we wanted to see how that would impact other physicochemical characteristics of allografts. We did specific surface area analysis with a method called BET, where an inert gas such as nitrogen is continuously flowed over the solid sample, or other way around, solid sample is suspended in a defined gaseous volume. The volume of gas absorbed is measured to determine the quantity of gas required to cover the surface of the sample, and that represents the surface area of the sample. So obviously with all those fibrils and complexity and nanotexture that you were seeing on porous, you would expect to see higher surface area compared to other allografts that we tested. And that was indeed 2 orders of magnitude higher for porous. When you look at the graph over here, you're not even seeing the surface area of other freeze-dried allografts because porous is off the chart over here. So what is the benefit of increased surface area? Why we brag about it? Why we keep talking about it? A larger surface area allows for more significant absorption of proteins and growth factors, which are essential for initiating and sustaining bone healing process by providing necessary signals for cell migration, differentiation, and proliferation. This means enhanced osteoconduction. Increased surface area provides more points of contact and space for the migrating cells to adhere, spread, and grow on the graft. This means de novo bone formation happens by contact osteogenesis. A larger surface area can also accelerate the degradation process, making way for new bone tissue to replace the bone graft material more effectively. So basically, by increasing the surface area, you're providing more chance for cells to adhere on the graft, and also more chance for the adhesion of more number of cells on the graft. And just to see what differences are there between these freeze-dried allografts in terms of surface area, we removed puros off the graft. And as you can tell, there aren't striking differences between them. The variation, the error bar, is a little bit big for Miniras, but not significant differences between any of these allografts were seen. Other property we looked at was the hardness. When we look at the hardness of puros, it's measured lower than the range of what we see with unprocessed human bone that is reported in the literature, which has been shown here with dashed lines. It's somewhere between 30 to 45. And it depends on where on human bone these measurements have been taken. Crayas falls within the range, however, and Allografts and Miniras are pretty much close to puros. It's hard to say what causes this, but I would speculate that any processing technique would remove some of the mineral content because you're dealing with oxidation, you're using solvents, chemicals in the process that may be removing some of that inorganic content, some of the calcium. The age of the donor would also matter. So it's so hard to tell what's happening here, but nevertheless, Crayas seems to be significantly harder than other allografts. Whether it's a good thing or a bad thing, I don't think it's necessarily a good thing because you're increasing hardness, you're reducing the resorption time, and increasing the brittleness. Keep that in mind because I'm going to come back to this in the coming slides. We also looked at the calcium and phosphorus content, and because we know that the rate at which calcium phosphate-based materials are resolved in vivo depend on calcium and phosphorus content and their ratio, among many other, obviously, biomaterial-related factors such as particle size, surface area, porosity, this list goes on and on. So both calcium and phosphorus content of puros, Allografts, and Miniras fell within the range reported for unprocessed human bone, as you see again with dashed lines in these graphs, except Crayas, that's being a little bit higher than other allografts. So with higher calcium content, higher hardness, you would expect slower resorption in vivo for Crayas compared to other allografts. And again, not only microarchitecture is impacted, but also properties such as hardness, calcium, phosphorus content are affected as a result of different processing that is undertaken. So we talked about increased surface area is good for cell adhesion, and we wanted to prove it. We took human bone marrow, mesenchymal stem cells, placed these bone grafts in the culture dish, obviously equal amount in each culture dish, and we seeded equal number of cells on these particles. After 1, 3, and 7 days, we came back and looked at the adhesion of the cells to the particulates. The images you're seeing here are fluorescent images that we took from live cells still on the particulates after 7 days. The glowing green points that you're seeing are live cells. So with puros, interestingly, no matter what depth of the field we went through, all the particles were covered with a lot of glowing green dots, which are live cells. But with Crayas, Miniras, and Allografts, actually the pictures that you're seeing here are the best case scenario that we tried to find and put in our paper because it was so hard to find live cells on the particulates, even we went through different depths of field. This was another confirmation that we got that, yes, increased surface area is helping with the adhesion of increased number of cells. Obviously, this is only qualitative examination. We wanted to quantify, count the number of cells that have adhered to each graft. So what you're seeing here in this graph is the number of cells at day 1, 3, and 7 of culture. Again, Puros is off the chart. We can hardly see anything with other freeze-dried allografts in this graph. And to check the differences, we had to between these allografts, we had to remove Puros off the chart so we can see what is happening here. But before we talk about the differences here, we see that number of cells is increasing over time. As the time goes by, more and more cells are adhering to Puros. As you can see, they increase from 1 to 3 to 7 days, and they are live. We are looking at the number of live cells. But when you're looking at other freeze-dried allografts, there is not much change happening over time, especially on Creas and Mineras. It's steady. Whatever could adhere in the beginning adhered, and there is not much happening after first or second day, except a little bit on Allografts. But we see this huge increase from day 1 to day 3 to day 7 on Puros. So once again, indicates that freeze-dried allografts are not as cell-friendly or attractive to the cells as Puros is in this experimental assay. We wanted to take a look at the shape of the cells because shape of the cells also tell us some stuff. They tell you how happy they are, how could they stretch themselves and relax and send their cell processes to adhere to the underlying graft material. So we are seeing that happening with Puros. You're seeing 4 cells in the picture. We have color-coded them red just so you can easily distinguish them. They have these cell processes that are coming out of the cells, cell body sticking to the complex surface of Puros. And this is an indication on how happy cells are on Puros. But if you're looking at the sad cells on the freeze-dried allografts, it's just so hard to tell they are cells because they don't look comfortable. They are needle-shaped. They don't show any cell processes, because the surface is so flat. There are no gripping points, no complexity for the cells to attach, proliferate, or differentiate. Another test we did was the alkaline phosphatase activity. This is an assay that shows the osteogenic potential of stem cells, meaning how many of these cells will differentiate it into osteogenic cells. Or in simple words, if you have a good allograft, when MSCs adhere to it, they're going to differentiate into osteoblasts and start laying bone matrix. So again, the same thing, same scenario, we see over and over and over with Puros. It's off the chart, higher alkaline phosphatase activity at 21 days for Puros versus other allografts. Among freeze-dried allografts, Allografts show a little bit more of alkaline phosphatase activity as compared to Mineras and Creas, which at this point is not even worth focusing on when Puros is 5 times higher. So, but this difference tells us something, that even between freeze-dried allografts, there are differences. Not all the freeze-dried allografts are the same. So a few takeaway messages, because I shared a lot of information. We learned that commercially available bone allografts significantly differ in their specific surface area, calcium, phosphorus content, and microarchitecture of bone tissue. And the differences result from different tissue processing and sterilization methods that different tissue banks undertake. And we learned that these differences impact the response of mesenchymal stem cells in vitro and may alter their biological performance in vivo. Obviously, this study was in vitro. We cannot directly link the findings to clinical outcomes because it's an in vitro culture, but we learned to be aware that these differences in the tissue processing impact cell response. So if cell response is impacted in vitro, it's also going to be impacted in vivo, and that may alter biological performance in clinical cases. We will come to that in the coming slides because I have included a few clinical studies that basically shows this, but at this point with our paper, this is what we can conclude. We also learned that pseudoplast process preserves the natural structure of collagen matrix and tissue integrity, so may contribute to enhanced osteoconductive potential compared to other freeze-dried allografts. And these are the information, the characteristics that should be taken into consideration when a graft is being chosen for a particular indication. Last but not least, findings are beneficial to help fully understand how these processing and sterilization methods that are different even between freeze-dried allografts change the characteristics of the graft. So you guys have to question the assumption that all allografts are going to exhibit equivalent clinical performance. You may want to try and see it for yourselves, which is fair, but I hope the findings I shared with you here helped you understand bone is bone until it is processed, and not all allografts are going to show the same clinical performance. And I'm sure now many of you are questioning, okay, this is all in vitro evidence. I don't buy into that. How are these reflected in the clinical performance? Show me evidence. Unfortunately, there aren't many clinical studies that have compared Puros to other freeze-dried allografts head-to-head. I have only summarized 3 of them here. One of which is what we sponsored and conducted in collaboration with NYU and UF, and the other 2 are studies conducted independent of us. Again, I cannot talk too confidently about the independent studies and their quality, but what I'm confident about is the outcomes of the study we have sponsored, which I will share in the coming slides. So this is what we have sponsored in collaboration with NYU. Dr. Coelho and Dr. Neba were the principal investigators in this study. It was accepted and presented at the AO in 2019 as a poster, and the manuscript is under preparation. This is a histological comparison of Puros versus Creos in extraction sites of 15 patients that were enrolled in this study. There were 2 teeth extractions in the same patient. So one of them was filled with Puros as a test group, and one was filled with Creos as a control group. And then core biopsies were taken from each grafted site at 12 weeks, so 3 months healing. What was reported was basically the standard set of data that you would see from these types of studies, like new bone percentage, residual graft percentage, soft tissue percentage. And what we are seeing here is significantly higher bone percent on Puros compared to Creos. But not so significant graft percentage or residual graft that is left in the sites, but Puros is slightly lower, Creos is a little bit higher, and then significantly higher soft tissue, connective tissue presence in the sockets with Creos as compared to Puros. So this is all good. The pictures of histology were also included in the poster for biopsy. They included, but when I looked at it, it wasn't enough for me. The images were taken at low magnification, so you can hardly distinguish between the residual graft and new bone. But at this level of magnification, what we can clearly see is more of connective tissue in case of Creos that has stained in blue. So I reached out to the histologist, got all the images back, all from 15 patients, both sockets, and took me, I think, a good 1 week to go through everything and spot some differences that I'm going to list in the coming slides. And the they are very interesting. I was so excited seeing. The very first observation is that when you look at that Puros particle here, compare it to a particulate of Creas at this point, you see a different color. Creas looks pale pink compared to the deep, nice, rich pink that you're seeing on Puros. That means uptake of the dye, the histology dye by Creas was lower. It didn't absorb the red dye as much as Puros did. Why? Because confirms our observation, higher calcium content of Creas. And we talked about it. The higher the calcium content, the less uptake of the red dye would be. Another observation is the chipped and cracked Creas particles weigh more than what is seen with Puros. Again, this confirms our in vitro findings of hardness that showed Creas had higher hardness than Puros because they have higher calcium content, they have higher hardness, so obviously they are more brittle. Packing them in the socket can break them. Again, you see similar chipping with Puros as well. I'm not saying it's not happening with Puros at all, but it's happening at an extremely low extent in random areas. The most interesting observation, however, here is what you're seeing as yellow arrow that I have put on the images. New bone has formed in intimate contact with Puros particle, is the new bone tissue and the osteoid tissue that you're seeing on top of this new bone, meaning it's collagenous, non-mineralized new bone matrix, and it will mineralize, turn into new bone. A nice line of osteoblasts around it, so it's covering all around. Puros particle in intimate contact new bone tissue is all around it, covering all nicely, beautifully around it. But when you're looking at Creas, there are some new bony islands that formed further away from the particle. It's not, again, yellow arrows are pointing at them. It's not in contact, and there are connective tissue or cellular level that is detaching the new bone from Creas particle. So for the reasons that we mentioned, either because the surface is flat or there is that organic film covering the particles or hardness or calcium, whatever it is, the cells do not like to adhere to the surface and lay bone right on the particle. They are sensing this bony structure and forming bone around it, but not on it. So that's basically a beautiful indication of contact osteogenesis that's happening on Puros, but not on Creas. I saw this at least, I would say, in 80% of Puros images that I reviewed, and probably the contact osteogenesis, I would say, like in 10% of pictures that I reviewed with Creas. Taking a further look again, another difference is that the bone is forming on Puros particles and branching out and filling the gaps between the particles. So this is one particle here, this is one in this corner, and then you're seeing this new bone is forming in intimate contact with the graft and branching out, filling up this marrow space. But when you look at Creas, you have a bone graft here, you have a bone graft here, and these are isolated bony islands that have formed in the spaces, trying to come close to the graft, but again, they don't like it. They're coming close, trying to turn away from them. So it all starts, like the bone formation starts in the spaces, then comes close to the graft, and there is always this gap that I'm showing with yellow arrows around the particle and new bone. It's not an intimate contact with new bone. So that's another different pattern of bone formation that we are seeing between Puros sockets versus Creas sockets. We enlarge the field of view just to look at a bigger area. If you look at this picture, it's so hard to tell where the new bone is, where Puros particles are, because Puros particles have incorporated so well with the formation of new bone, and have become indistinguishable. So I put these yellow lines around where the new bone is for you to trace the new bone tissue. And what is remaining is porous particles. As you can tell, the particles are interwoven with new bone. But when you look at the socket with Kreyas, there are bony islands here and there, and the particles are scattered here and there. There is no incorporation or direct contact happening. I'm not a clinician, obviously, but if you were to place an implant in this socket versus an implant in this socket, first of all, the feel would be different because you are placing an implant in an area that has a lot of new bone in the case of puros, less residual graft, less connective tissue. But here, I would think it's going to, here with the Kreyas socket, I would think it's going to feel a little bit like a little bit more soft and mushy because you have a lot of connective tissue, not too much new bone. Here, implant is in contact with new bone. Here, who knows, may or may not be, depending on where you're placing it, there is new bone. So overall picture looks very different. And I'm sure it's going to impact the stability of the implant and then peri-implant bone formation. Just remember, again, these are 12-week histology slides. And I think we have seen that with puros, you don't need to wait for 6 months. And we always say that 3 months is good enough to re-enter. This is another indication that for Kreyas, 3 months is not good enough. You need to wait a little bit longer to re-enter. And who knows what's going to happen at the longer time point. Basically here, incorporation comes into play. We can say the incorporation of puros is much better than Kreyas in these field extraction sockets. This is another pattern that I observed, maybe too scientific, but I'll try to explain. Usually when bone forms around an implant or a graft particle on the old bone, new bone interface, it curves. The reason for curving is that it provides mechanical strength when facing external stress forces. So this type of curving pattern provides more strength for the bone to withstand mechanical loads, and it's a natural behavior in new bone formation. So if you go back and look at the literature, there isn't much out there, but they are called Boud curves, B-A-U-D, Boud curves. So what we were seeing, which is really, really interesting and is happening with puros particle, is that we are seeing these Boud curves. So you have a graft here, new bone forming on both, and then curving. So this is like another curving of the new bone formation. This is another curved new bone connecting the two grafts and then curving. So these are all Boud curves, nicely formed. Basically, I would say that the environment and the cells recognize puros particles as bone, nothing foreign. This is why they are exhibiting this natural bone formation pattern. So you're seeing all these curved bone and between bridging the two particles together, natural behavior of bone. So the cells in this environment, they see puros as your natural bone tissue, nothing else. So new bone that is formed in this manner is actually very strong. It's not gonna break apart that easily. So that's the beauty of or the benefits of having Boud curves. But Kreyas, again, you're not seeing that bridging pattern because nothing is forming on the particulates. And when I say nothing, it doesn't mean that contact osteogenesis never happening at all on Kreyas. That would be a lie. But again, I repeat myself, if it's happening 80% on puros, it's only happening maybe 10-15% with Kreyas. Just wanted to make it clear. But anyways, most of the times, this is what I see with the histology images, isolated bony islands, no bridging the gaps, no direct contact osteogenesis, and no Boud curves. So these are the additional observations we had to add to what the group reported. Different pattern of osteogenesis that's happening on puros, which is contact osteogenesis, but with Kreyas, it is not on the particle. It's forming somewhere else, trying to come in contact with particles. And enhanced incorporation of puros and less residual graft compared to Kreyas. This is the second clinical evidence that I mentioned. I included here. It was published in 2017 in Ajami. They looked at the histomorphometric outcomes of puros versus another freeze-dried allograft, in this case being Mineros. So they had 34 patients. They did sinus augmentation and randomly assigned with 1:1 ratio of cortical cancellous bone, either puros or Mineros, mixed both of them with autogenous bone. Unfortunately, the histology that I reviewed in this paper was not correct. The method they described, how they prepared the histology slides, did not match with the images they reported in the paper. So I did not want to put something that I believe is wrong and try to explain it to you. But with the quantitative data, they report more mineralized tissue with puros than Mineros, even though the difference was not significant. But the major finding or conclusion of the paper that others make at the end is that they say the biopsy of puros showed no osteoblast activity, but with Mineros, they saw a lot of osteoblasts, fibroblasts, and inflammatory cell activity at a greater number. And they make this statement that solvent dehydration process stimulates early remodeling compared to freeze-dried protocol, which is true because we know, as we said, with puros grafted site at 3 months, the amount of bone is good enough. You can go back to place your implant. So obviously remodeling is happening at a faster rate than the particles are resolved and new bone is formed. The turnover, in other words, is faster. And finally, the third study is the one published in 2019 in J. Perio, compared the tooth extraction sockets that were filled with puros versus other freeze-dried allografts, in this case, solvent. They had 44 patients needing extraction and ridge preservation. So randomly assigned the patients to receive puros or solvent allografts. Then they took core biopsies at 12 weeks. So what they report here is again interesting because they're not seeing much differences between puros versus solvent in terms of bone percentage, even though it's obviously higher for puros, but not statistically significant. And then residual graft is pretty much similar between the two. The authors make a very nice statement here. They are saying that a solvent allograft came from a 50-year-old male donor, whereas puros came from a 73-year-old male. So they speculate that the older donor for puros may have negatively influenced the formation of vital bone compared to the younger donor. So they're talking about the age of the donor may impact the turnover of the allograft, among other factors. If that was the case, with the difference between this old donor for puros and the younger donor for solvent, yet you're seeing higher percentage of bone on puros is telling us something here. Then when you take a look at their histology data, they're only reporting images from solvent. In this paper, they did not report histology pictures from puros. So I went back to their earlier study that they had shown histology of puros and put them here together so you guys can see the difference. Again, it's very interesting to see and confirm the same observation that we had with our histology images. You see these white areas, they are that I have tried to put arrows on them. They are gaps between the new bone tissue and solvent particulate. But when you look at puros, It's all in intimate contact. And the gap here, look at this gap here, it's huge. It's confirming that contact osteogenesis is happening here. No gap, intimate contact, but there's this large gap between the bone and the graft on the other products. So there are only 3 articles that I could put here as clinical evidence showing Puros outperforming other freeze-dried allografts in head-to-head comparison. Hopefully, there will be more in the future. And just to conclude what we talked about and what we learned, I may be repeating myself, but keep in mind new bone forms in direct and close contact with Puros, and this is an indication of successful incorporation. Replacement of the particulate with viable bone. And obviously, it is the complexity of Puros surface. It's nanotopography, those collagen fibers that are nanometers in diameters, providing nanotopography to cells that help with mechanical interdigitation of bone tissue with the particulated cells. So the same as that is important to have all sort of, scale ranges of topography and complexity on dental implants, on metallic implants for bone to form on it, same applies for the graft particulates. The more the surface has that complexity, the nanotopography, it's better in terms of contact osteogenesis, bone formation, mechanical interdigitation. And obviously, we're seeing increased new viable bone, less residual graft with Puros, and that's an indication of its faster turnaround and remodeling compared to other freeze-dried allografts. And finally, I have a couple of slides here left that I will be talking about Puros custom block. So what is Puros bone block? It's a patient-specific CAD/CAM design block that is pseudoplast processed cancellous bone. It's machined from cadaveric femoral heads or tibia, depending on size, using a very high precision CNC machine to accurately form irregular shapes. Commercial launch was in Europe in 2014, and it was launched in North America in November of 2021. It's used in large mandibular or maxillary defects. Again, its large surface area, as well as the preservation of bone collagen matrix, allows for vascularization and faster healing. So what we did here was similar to what we did with cancellous particulates. We took a Puros bone block and we looked in SEM to see if the collagen compartment is preserved to the degree that we saw with cancellous particulates. So the middle image you're seeing here, obviously you're seeing these sharp parallel lines. Those are the lines that have been created during the milling and shaping of that block. And these two windows are where we zoomed in and took SEM images. The red one is this one. As you can see, the beautiful collagen compartment, and then small the collagen fibrils going obliquely on the underlying compartment, and then looking at the different directionality of the collagen fibers obviously are different in depending on the cut you're looking at. So again, different area that we focus on, we see that individual collagen fibrils are clearly seen within the bundles. So again, it's the same pseudoplast process. The microarchitecture has been preserved to its best. And I have summarized one study here. It's a case that presents a 66-year-old healthy female non-smoker who lost her right mandibular molar for a long time. And in the past, she had the implant placement, failed due to a fracture of the implant. And because of the high risk of mandibular nerve damage, implant was left in the jaw. It's a kind of a sleeping implant and was completely covered with bone over time. And since the jaw was completely atrophic and short implants were not an option, a vertical ridge augmentation was required. Puros bone block was designed and milled based on the CBCT using CAD/CAM, and it was fixed in place with screws. A 6-month maturation time before implant placement was followed, and an additional period of 3 months for healing following the traditional healing protocol after implant placement to allow increased maturation of bone graft with a 15-month follow-up. So as you can see, there is a picture here that shows atrophy before surgery. And then this is what has been designed. It's a CAD/CAM design. This is Puros bone block, and then it's placed 5 months post-op. You're seeing this beautiful construct here that is preserving the ridge height. It's a post-op radiograph showing basically the structure of the Puros block in this picture. So minimal to no volume loss of the allograft bone block 5 months after placement. They see 46.6% mineralized bone after 6 months shown by histology. So pretty successful. And then unfortunately, again, the histology slides were not too clear in the paper, but nevertheless, we could see that the biopsies showed a well-vascularized lamellar bone with fatty incorporations without any avital like allograft remnants. So presence of osteocyte lining the cell macrophages and blood vessels indicated healthy vital bone tissue. So what you're seeing here is the yellow lines are new bone, and the structure of mineralized bone block is outlined by red lines after 6 months of healing. And that's the zoomed in picture, again showing new bone formed inside the porous structure of the Puros bone block. So all vital bone, and the structure, the bone block is still intact and in its place. It's actually a very successful product. So with that, I will end the presentation. I think we have time for questions.
Yes, thank you so much for your presentation tonight, Dr. Ajami. We can hear your passion for this subject and definitely tell your expertise and experience. We have some great questions coming in. Our first question is, I was taught that bone particles acted as a scaffold and then were resorbed. Can you speak to this?
So it is all about remodeling, and again, depending on what you have. If you have something like bioas, obviously it's going to be acting like scaffold. It does not resorb. It just stays there. It preserves the volume of your defect, and it sits there, bone forms, fills in the gaps, and bioas is there to preserve the volume. But if you're looking at something like Puros, as I mentioned, your body, the environment sees it as bone tissue, maybe seeing as dead bone tissue or old bone tissue. And then osteoclasts are going to come and resorb the surface of Puros particles. And when resorption is happening, bone formation is also happening. So that's why what I was showing, that new bone is in intimate contact with Puros particulates. Whether there was a resorption on that site or not is debatable. I was seeing scalloped regions, but that's scalloped regions that are specific of resorption areas may have been coming from the source bone tissue. But that's what is happening. It's the remodeling of bone, remodeling of Puros particulates the same way. It could be resorbed by osteoclast, new bone can form on it, or new bone starts forming on it, and it just interdigitates with the new bone, and it eventually gets resorbed by the natural remodeling of new bone, because you're having a lot of viable bone in the site, and there's a lot of remodeling happening, and bone cells are seeing porous particles as your bone tissue. So remodeling is happening similar to remodeling that's happening with bone. But again, if you're talking about something like bioos, it's going to sit there and it won't remodel.
Okay, we have another question. Any difference between mineralized and demineralized cancellous and cortical types of graft on performance?
So cancellous particles have obviously more like higher surface area. They resorb faster than cortical. Cortical bone is usually used, bone particulates is usually used when you want to have some of that scaffolding, space maintenance, volume preservation of the defect. And demineralized bone is another story, because you're basically getting rid of inorganic content, and all you have is all the growth factors and cytokines and proteins, and that's kind of helping with the osteoinduction process. So obviously one cannot replace the other. You can, and each of them have their own indications. And as I said, that I love that quote from Stevenson, it's the job of the clinician to decide, depending on the patient factors and a lot of other things, what would be the most suitable. But definitely there are differences between cancellous, cortical, and demineralized bone in terms of their clinical performance. I have heard many people mix DBM with their cancellous. Some do cortical cancellous and mix with DBM. There are a lot of different use for different of them. And honestly, there is not like one gold standard that we can point at and say, okay, this can do the magic for everything. Even with puros, we don't say that. So yes, there are differences between them. The freeze drying of cortical bone would show different properties compared to solvent dehydrated cortical bone. Methods that they use in making DBM is also going to impact the performance of that DBM product. So yes, they are going to show different clinical performance and indication. Obviously, the choice of them for the indication is up to the clinician.
Okay, we have a few more questions. What is the biggest differentiator between Puros and other allografts on the market?
That's a very good question. So the biggest differentiator is, in my opinion, the preservation of the microarchitecture of the bone. That's very important, because that's basically the architecture that puts that gets into the body, and your body, the cells are seeing it. And if it looks like bone tissue, it's going to be remodeled like bone tissue. And that preservation of collagen fiber happens to the level of individual collagen fibers that we, as I mentioned, we saw even the cross banding. So very to the very detailed, it's preserved. And another differentiator is actually the specific surface area that is, again, as a result of the preservation of collagen matrix and the complexity of the surface. So it's not only meeting the standards of not having any pathogens or disease transmission, etc., which is obviously a standard that all the allografts have to meet. These two are major distinguisher from other allografts, and it's the list is again long. I can mention a lot of other things like contact osteogenesis is happening, and less residual graft is seen. It's early to go back. It's like 3 months is enough time to go back. So you basically accelerating the treatment time. So there are a lot of things, but to me, when somebody asks the question, it's the preservation of the natural architecture of bone and its high specific surface area.
Okay, we have another question. It is, besides the measurement of ALP, was there any assessment of osteonectine, osteopontine, osteonectine, or BMP?
No, unfortunately, we didn't go to that extent. We have limited basically research resources in our company and in my team. So there are actually a lot of things that we want to do, but for the sake of this study and publication, we did not go that far. Alkaline phosphatase was the only thing. We really love to even look at the amount of growth factors and other stuff that is preserved with Puros, but unfortunately we did not have the resources, but that's a very good point.
Okay, I think this is the last one. What differences did you see when you compared Puros to unprocessed bone?
So the differences were again to the microarchitecture of the bone. Obviously, unprocessed natural bone had a better collagen matrix when we were seeing. We can't see cells because both of them were bleached and got rid of cells, even though we call it unprocessed. That means we didn't put through too much like different extreme temperatures, extreme pressures, but in order to be able to handle, they had to do certain antibiotic wash, etc. So what I was looking at was more the microarchitecture and the differences that I could see on osteoclast resorption, site complexity compared to Puros, was that obviously unprocessed bone had less damage to the architecture compared to Puros. Puros is processed. We can't deny that. There's a processing, even though it's very gentle and done to the best possible. I would think that maybe like 10 to 15% of maybe the architecture gets ruined. And that's the only difference that I was detecting. Other than that, every time I went to look at human bone and then put Puros in, I could find a matching site that matched in terms of architecture. But again, certain damages to Puros was there, and I did not see it with natural bone, with unprocessed human bone.
Okay, I think that we are out of time, so we're going to go ahead and wrap up. Thank you so much, Dr. Ajami. It was a pleasure to
Thank
have
you.
you as our guest and speaker for this webcast. Thank you so much for sharing your expertise with all of us.
Thank you.